Robert, are you still there?
No po. Dok, ayaw lang po mag-switch ng slides.
We can switch it for you.
Hmm.
We can switch it for you, Robert. You begin and then you tell
Okay
us
po.
when you're about to change slide. I can switch it for you. Okay, sige.
Okay po. On slide number 5 po, slide number 1. So here on this slide, a general algorithm for evaluating patients with jaundice is depicted. To synthesize this, a logical approach usually involves integration of the patient's history, physical examination, and laboratory results, which altogether, they can provide an estimate of the likelihood of patients with jaundice either due to a disorder in metabolic liver diseases or either due to biliary obstruction. So, square, as directed by the arrows, we can see that if levels of the serum alkaline phosphatase and aminotransferase activities and even platelet counts and prothrombin time are
Robert,
normal,
Robert, sorry.
this,
Robert, let me interrupt you. This was already discussed by Mikhail.
yes
Just
pa,
go ahead with the diagnostic
okay pa,
abnormalities. Diba? We agreed that this
okay pa,
patient has extrahepatic obstruction. Okay? Sige.
apa, okay po. So if all of these lead to the possibility of biliary obstruction, therefore it necessitates hepatobiliary imaging. So we have the following imaging modalities: your abdominal ultrasound, abdominal CT, magnetic resonance, cholangiopancreatography or MRCP, endoscopic ultrasound or EUS, and your endoscopic retrograde cholangiopancreatography or ERCP, and your percutaneous THC or transhepatic cholangitis. Now, let's dig deeper into the advantages and disadvantages of each of the imaging modalities on the next slide 2 out of 4. Okay, so as what was mentioned a while ago, abdominal ultrasound is the initial imaging test in jaundice patients with suspected hepatobiliary disease. It can demonstrate cholelithiasis and even intrahepatic lesions which are more than 1 centimeter in diameter. Advantages would include being non-invasive, it is portable, and less expensive compared to other imaging studies. On the disadvantages, this would include being operator dependent, potential difficulties, especially in obese patients and in those with excessive bowel gas, which may overlie some organs like the pancreas during imaging. We have your abdominal CT. So also on slide 2 out of 4. Abdominal CT usually involves the use of intravenous contrast medium, and this is another alternative medium which is also non-invasive. It permits accurate measurement of the biliary tract, similar to that of your ultrasonography, although it can also measure lesions as small as 5 millimeters. It is also non-operator dependent, provides technical superior images in obese persons. So compared to ultrasound a while ago, this one can be used for obese persons. Disadvantages would also include lack of portability, exposing patients into radiation, ionizing radiation, and is also more expensive compared to that of ultrasonography. So we must also take note that a while ago I mentioned about it using intravenous media of kidney injuries and also in patients who are hypersensitive to any of the components. So next slide, slide 3 out of 4, we have your MRCP. This is a technical refinement of a standard MRI. It also permits a very rapid and clear-cut delineation of the biliary tract. Also another non-invasive procedure and also superior in terms of imaging quality. Moreover, this can be performed during in times that allergic to the contrast medium in performing abdominal CT, and also if there is a question of hepatobiliary mass. So next, we have your ERCP naman. This permits direct, so take note of the word direct, visualization of the biliary tract, and this highly accurate in the diagnosis of biliary obstruction. So what's nice about ERCP is that if of the biliary obstruction, we can also perform interventional maneuvers during the same session. So what are these interventional maneuvers? So we have sphincterotomy, stone extraction, and etc., which will be discussed further by the next reporters. Similarly, if so a neoplasm detected, we can proceed in doing biopsy and brushings for cytology. And for the complications, we have pancreatitis as the major complication of ERCP. So another important thing to note in ERCP is that its limitations is that it is largely limited to lesions distal to the bifurcation. So take the word distal. Distal to the bifurcation of the left and right hepatic bile ducts. So distal. So next slide, last slide, 4 out of 4. Um, we have percutaneous THC. So this procedure complements that of ERCP. So to differentiate it from ERCP, this time percutaneous THC is advantageous when the level of biliary obstruction is proximal. So proximal to the common hepatic duct, or if ERCP is not possible to be performed. A disadvantage of percutaneous THC would be that it is technically challenging in the absence of dilatation of the ducts. And lastly, we have your EUS. This has the potential advantage of permitting biopsy of suspected malignant lesions. And in under appropriate circumstances, the operator can proceed directly to ERCP for definitive biliary decompression. EUS is also useful in circumstances in which the patient is high risk for complications in ERCP or percutaneous TH. So
Okay.
that's it for the imaging
Robert,
modalities.
Robert,
Yes po, Doc.
you have already told us the advantages of one test over another, diba? One imaging over another.
Apologies.
Can you go back to your first slide and tell us now, how do we make use of this? Your
Okay,
first
Doc.
slide.
So um, the sequencing of on the use of these imaging modalities would depend on several factors. So basically, the most important factor to look at would be your clinical likelihood of biliary obstruction. So if there is low, intermediate, or high. So that's on the 5th box from going downwards. So if we
Robert,
determine
you
the
can use your cursor. Yes.
I my slides are not loaded. Naka-blank lang my device.
Okay, sige. Continue. On the fifth box. Okay.
On the on the fifth box po, on my slide 1 out of 4, on ayan po, on slide, so if the clinical likelihood of biliary obstruction is low, so we can proceed to biochemical studies for specific causes of liver diseases. While if clinical likelihood is intermediate, so we can do MRCP or endoscopic ultrasound. Then if bile ducts are dilated, proceed to ERCP or THC. So basically, if clinical likelihood is high, we can directly proceed to ERCP or THC.
Okay.
Then
Okay,
we're on
next.
therapeutic intervention.
Okay.
That's it. Thank you po.
Good morning, everyone. Naririnig po ba?
Yes.
So I'll be discussing how we came up with the differential diagnosis. Going back to the algorithm for patients with jaundice, since both bilirubin and other liver tests of the patient are elevated, we'll be able to rule out disorders causing isolated serum bilirubin, such as some inherited disorders and hemolytic disorders. So now we are to distinguish whether the pathology is hepatic or cholestatic in pattern. Since the patient's ALP is relatively higher and out of proportion to the levels of AST and ALT, we can now conclude that the abnormality is cholestatic in pattern. Based on the ultrasound result of the patient, the ducts are dilated, and so we are now able to narrow down the diagnosis to extrahepatic cause of cholestasis. Considering the risk factors of the patient, medical history, and clinical presentation, we are now down to three differential diagnoses. These are choledocholithiasis, malignant biliary obstruction, and benign strictures of the bile duct. Old age is a risk factor for both choledocholithiasis and malignant biliary obstruction. Jaundice and icteric sclera seen in the patient is a common manifestation of all three differentials. We should take note that the patient presented with painless jaundice, which is usually presented in patients with malignant biliary obstruction. However, painless jaundice can also be seen in ones with choledocholithiasis, especially in chronic cases and benign strictures of the bile duct. We should also put importance to the past medical history of the patient, specifically cholecystectomy, which can predispose one to choledocholithiasis and benign strictures. Also, the patient had prior TB, which is a risk factor for benign biliary obstruction. And lastly, cigarette smoking is a risk factor also for malignant biliary obstruction. Thank you.
Rovelin,
Yes, Doc.
Rovelin, you mentioned only three differential diagnoses for obstructive jaundice. There are other differential diagnoses. Can you enumerate a few of them?
Yes, Doc. Other causes of obstructive
Obstructive,
jaundice are gallstones, um,
gallstone disease producing cysts. What else? Kasi you're biased on mentioning only these three. One of your
yes,
job is to mention the entire differential diagnosis, and from that, then you choose these three for the reasons that you have mentioned. So there are other reasons like choledochal cysts. Some patients may also have ascaris
yes, Doc.
producing obstructive jaundice. All right. So
Yes,
next.
Doc.
Hello, good morning. So now we move on to the first differential, which is choledocholithiasis. So, like stones in the gallbladder, stones in the bile duct may remain asymptomatic for years and known to pass silently into the duodenum via the ampulla of Vater. Unlike stones in the gallbladder, which become clinically evident as benign episodes of recurrent biliary pain, stones in the common bile duct, when symptomatic, may cause life-threatening complications. This this is also because of the anatomy of the gallbladder. As you can see in the picture, the common bile duct is proximal to the ampulla of Vater and pancreatic duct, thus causing the life-threatening complications. Therefore, discovery of choledocholithiasis should be followed by appropriate intervention. For the epidemiology, the passage of gallstones in the common bile duct occurs in approximately 10 to 15% of patients with cholelithiasis. Gallstone formation is said to increase after the age of 50, thus the incidence of common bile duct stones also increases with age. It's important to note that undetected stones are left behind in approximately 1 to 5% of cholecystectomy patients. So for the pathophysiology of choledocholithiasis, it is gallstones may pass. Nawala.
We lost the slides.
Yes, Doc, nawala po siya bigla. Wait lang po, Doc.
Okay.
Sorry po.
Okay.
Ayan. So, going back, gallstones may pass from the gallbladder into the bile duct or form de novo in the duct. Majority of bile duct stones are cholesterol stones formed in the gallbladder, which then migrate into the extrahepatic biliary tree through the cystic duct through the common bile duct. Stones in the bile duct usually come to rest at the lower end of the ampulla of Vater, again causing the life-threatening complications, which therefore causes inflammation and obstruction, producing symptoms such as biliary colic, which is the most specific and characteristic symptom of gallstone disease and characterized as constant and long-lasting. Therefore, biliary obstruction raises biliary pressure and diminishes the bile flow. So, the major factors that determine resulting symptoms of choledocholithiasis is the rate of onset of obstruction and the amount of bacterial contamination of the bile.
Okay. Pleasant and happy morning to our dearest doctors and to my fellow future doctors. Let me present to you the complication of choledocholytitis. So first, we have cholangitis, or the inflammation of the cholangiocytes lining the biliary system due to an obstruction secondary to producing a bacterial infection. So it has two types, the non-suppurative type, which is the most common, as well as the suppurative, which is exemplified by pus formation. Clinically, both of them would manifest with severe biliary pain, jaundice, and fever spiking with chills, which is known as the Charcot's triad. On the other hand, the suppurative type has two additional clinical manifestations, which is the altered mental status, for example, confusion, and signs of septic shock, for example, hypotension, which is known as the Raynaud's pentad. Another important difference between the two would be the response to antibiotics. So the non-suppurative has good response to antibiotics, therefore the treatment would be antibiotics. But there are some instances that would also require biliary drainage. On the other hand, suppurative has poor response to antibiotics, therefore it requires treatment such as surgical or endoscopic treatment. Back,
Arnold?
yes,
Arnold, sorry. So you mentioned that for non-suppurative cholangitis, it's just antibiotic and it's rarely that you use biliary drainage. Does your book say
uh,
that?
the,
Kasi
there,
mention mo sa pag may you need to drain. But for non-suppurative, you said good response to antibiotics. Um, Parang you mentioned that it's not very common that you need to drain it.
there will be instances that we also do biliary drainage for non-suppurative.
Is that the actual statement in your book that there are just instances where you have to drain it?
No po, Doc.
Okay, because you have to understand that the reason for the infection is there's an obstruction, and then the obstruction is the one that's causing the bacteria to. So even for non-suppurative cholangitis, you still need drainage. That's
Yes,
still
Doc.
the standard of care. It's not just antibiotics.
Okay po, Doc.
Okay.
So to everyone, so maybe what Arnold is just trying to say is that for patients with Raynaud's pentad, the the intervention has to be urgent and compared to that of non-suppurative cholangitis, wherein it can be early, meaning to say you can wait a little bit longer as compared to suppurative cholangitis. So the timing of performing therapeutic intervention should be faster for patients with suppurative cholangitis. Okay,
Noted po,
next.
Doc. Next, pancreatitis. Okay. For the gallstone producing pancreatitis, there are several hypotheses that could explain this. So looking at the image on the right, we have the common bile duct as well as the main pancreatic duct joining together the common channel known as the ampulla of Vater, then draining towards the second part of the duodenum via the major papillae, which is controlled by the sphincter of Oddi. If there's a stone obstructing the ampulla of Vater, the bile which normally drains to the duodenum would go towards the main pancreatic duct. Therefore, there will be mixture of bile as well as pancreatic enzymes, in the long run producing pancreatitis. Another reason is that if the stone obstruct the entrance of the pancreatic duct, the pancreatic enzymes would pull inside the pancreas, producing pancreatitis as well in the long run. And last reason would be the transient incompetence of the sphincter of Oddi. Okay, if this is incompetent, the bile as well as the pancreatic enzyme wouldn't be able to drain within the duodenum, producing again pancreatitis. Lastly, we have secondary biliary cirrhosis. Okay. The prolonged obstruction of the extrahepatic biliary tree, for example, with choledocholicitisis, would produce secondary inflammation. If this is further aggravated by cholangitis, there would be further inflammation. Those marked inflammatory processes could ascend upward to the bile canaliculi in the portal tract, producing periportal inflammation, repair, then fibrosis, and in the long run, produce a cirrhotic liver, thus called the secondary biliary cirrhosis. Although this is more common with strictures or neoplasm, it could also occur in the setting of choledocholicitisis. And another thing, this is usually progressive even after the removal of the stone. Thank you.
So, the diagnosis of choledocholicitisis begins with the initial evaluations of the patient's laboratory studies and transabdominal ultrasound of the right upper quadrant. Particularly, we are looking for signs of biliary obstruction. In the study of Copeland, they managed to find independent predictors of common bile duct stones, which are elevated gamma glutamyl transpeptidase, alkaline phosphatase, and total bilirubin. In ultrasound, we would be looking for visualization of the stone, which can be found in 50% of those with choledocholicitisis, and or the dilatation of the bile duct, which is more commonly found in 75% of those with choledocholicitisis. Since the normal diameter of common bile duct is usually less at 6 millimeters, anything above can be considered dilated. However, as mentioned by Dr. Velasco, anyone who has previously undergone cholecystectomy may have a more dilated common bile duct. And so, as suggested by another study, the cutoff should be greater than 8 millimeters. And to note, according to the American Society of Gastrointestinal Endoscopy, post-cholecystectomy patients with normal liver biochemical test results and normal ultrasound findings are very unlikely to have choledocholicitisis. So once initial evaluations are done, we can then follow this algorithm set by the American Society of GI Endoscopy. And this risk stratifies patients based on certain clinical predictors and thus helps us in our management. I will later enumerate the clinical predictors in the following slides. So for those with a low likelihood of choledocholicitisis, they actually don't show any of the clinical predictors, and thus has a less than 10% chance of having choledocholicitisis. And so they instead could have laparoscopic cholecystectomy for their symptomatic cholecystectomy. Furthermore, for those with an intermediate likelihood of choledocholicitisis, they have a 10 to 50% chance, and so they benefit from additional biliary imaging. The options are as follows. So they could have a laparoscopic IOC or intraoperative fluorocholangiography or laparoscopic ultrasound. And if negative, then they could also have laparoscopic cholecystectomy for their symptomatic cholecystectomy. If positive, then they could undergo laparoscopic common bile duct exploration or post-operative ERCP. Another option is preoperative EUS or MRCP. And if positive for common bile duct stones, then they could move on to preoperative ERCP for stone removal. And finally, for those with a high likelihood of choledocholitis or greater than 50% chance that they have it, they require further evaluation, thus prompting preoperative ERCP. So in either case of intermediate or high suspicion, if the results are positive for choledocholitis, we want to remove the stones. So since those with low suspicion do not require, yes,
Kim,
yes.
how do we know if the situation is low risk or intermediate or high risk for common bile duct stone?
For those with low risk, they don't have any of the clinical predictors, and then the clinical predictors for intermediate are listed here.
Okay. Thank you.
Okay. Yes. So for those with intermediate suspicion, they may present with any of the following: abnormal liver test, age of greater than 55 years old, a dilated common bile duct on ultrasound, or a total bilirubin of 1.8 to 4 milligrams per deciliter. In which case, we would have them undergo either endoscopic ultrasound, as seen in this picture here, where you see the distal bile duct and the stone inside. Or they could undergo the magnetic MRCP, where you can find filling defects which indicate the stone. So as mentioned before, these are non-invasive and have high specificity and sensitivity, and we would prefer these as over ERCP in intermediate suspicion patients because, first of all, it's non-invasive and has a less risk of adverse events that ERCP may bring. For those with a high clinical suspicion, they could have common bile duct stones on imaging, a total bilirubin of greater than 4 milligrams per deciliter, and a dilated common bile duct, or ascending cholangitis. Now, one thing to point out is that the original guidelines just asked for a total bilirubin of greater than 4, but a study evaluating these guidelines recommended that we combine total bilirubin plus a dilated common bile duct to improve the specificity for choledocholitis. So once there's a high suspicion, the next step is ERCP. Now this is both diagnostic and therapeutic, as mentioned before, as it allows visualization and removal of the stone. Another option is the percutaneous transhepatic cholangiogram in the case that ERCP fails or is unavailable.
Kimberly?
Yes?
Sorry for me to interrupt. Let me ask you. How about patients with acute pancreatitis? Where do you put them? Low, intermediate, or high risk?
I would put them in high risk, doc, because I believe pancreatitis is a complication.
Okay. So patients who develop pancreatitis, they are at high risk of having choledocholitis. Okay. Continue.
Okay. So as mentioned before, if there is a positive result for choledocholitis, we want to remove the stones. What differs in each of these treatments is just the timing of ERCP in relation to the laparoscopic cholecystectomy. If choledocholitis is suspected before the lap chole, then we can do a pre-op ERCP, papillotomy, and stone extraction. If it is discovered intraoperatively, the surgeon has the option of doing a laparoscopic exploration of the bile duct or a conversion to an open cholecystectomy, or they can continue with the laparoscopic cholecystectomy and then have the patient return for a post-op ERCP.
Yes, Dr. Chan.
Yes, Kimberly, thank you very much. Thank you very much for the great presentation. But you see, you are always mentioning cholecystectomy. Let's try to go back to the patient that we're discussing. The patient already had a cholecystectomy. So how are we going to treat the patient now?
Yes, in the third option, after the cholecystectomy is done, but there's still common bile duct stones, then they would do postoperative ERCP, papillotomy, and stone extraction.
Thank you.
Mhm. In the case of high-risk patients, such as older adults with severe concurrent illnesses, they would just do the endoscopic removal of bile duct stones without the cholecystectomy.
Okay. Kimberly, what
Yes.
if ERCP fails?
We have the option of the PTC, the percutaneous transhepatic choleoangiography.
Okay. Any other option? But of course, it will be the last.
Your second line.
Oh, the laparoscopic exploration of the bile duct.
Surgery.
Surgery.
Okay. Okay, but that will be the last option.
Yes.
ERCP, if it fails, you can do THC, transhepatic cholangiography, and probably do a rendezvous technique that is for us, but we can still manage. But if everything fails, that's the time that you think of surgery. Okay. Next. Yes, Dr. Ruiz.
I think, Kimberly, that was very good, but I think we need to put the case into its right context. I agree with Dr. Chan in asking the question a while ago, but you see this, if you look at the regimen or this treatment regimen, it tells us that at this particular time of treatment, the patient has gallbladder stones at the same time presents with symptoms or signs of obstruction. Now, that's why it said post-op ERCP. So that means at the same time frame. Okay, but in our case, when was the cholecystectomy done? It was years back, right? And therefore, you now have a patient who had previous cholecystectomy, so in the past, no? And now presents with obstructive jaundice. Although the answer would be the same, meaning you will do ERCP, but I don't think you label it at this point in time as post-op ERCP.
Okay.
Okay, so the context of this patient now is different from the context of the patient that you are discussing here in your treatment regimen. So you need to just putting the context in your mind differently, because if you will see patients later on, okay, and they have a past history of cholecystectomy years back, you might not be able to contextualize this treatment regimen. So just be aware of that, no? The history of the patient is different. Okay, that's all.
Thank you. Next.
Good morning, doctor. So for our next differential diagnosis, we will be discussing malignant biliary obstruction and highlighting the following causes and risk factors. So for malignant biliary obstruction, yes po, Doc.
Dr. D, before Shara continues with the presentation, I think you need to ask the last member of the group.
Yeah. I forgot. Kim?
Yes, po.
What do you think this is choledocholithiasis?
The patient has the risk factors for choledocholithiasis.
No. You start with the patient having
obstructive jaundice.
Obstructive jaundice.
The background of someone continue. Yes, Dr. Ruiz.
Yeah, that's what I mean. No, you have to put the case into its right context. You can say in a patient who has cholelithiasis. So this is now a patient who has obstructive jaundice. Do you get it, Kim?
Yes.
Okay, so and then on a background of, so that's what Dr. D's direction is. Okay, go ahead.
Okay. So the patient is presenting with obstructive jaundice with a background of advanced age of 65 years old, abnormal liver tests, and evidence of dilated ducts.
Then why choledocholithiasis?
Um,
Yes, John. Yes, John Corpus, you raise your hand. Then why not malignant biliary disease or benign stricture? Why choledocholithiasis?
The clinical features mentioned are risk factors for choledocholithiasis.
What risk? It's not the age.
The jaundice, the abnormal liver tests, and the evidence of dilated ducts.
Yes, I agree. These are signs of obstructive jaundice, but this is not, or these are not risk factor for choledocholithiasis. This just tells us obstructive jaundice.
Mm.
The history of?
The history of the cholecystectomy.
Yes, remember the first few presenter was telling us a while ago that patients may remain asymptomatic for years?
Yes.
Yes. Okay. Okay, next.
So we will, as I've said a while ago, for the second differential diagnosis, we will be discussing malignant biliary obstruction and highlighting its causes and risk factors. So malignant biliary obstruction, it comprises majority of the biliary neoplasms, and this is further subdivided into categories such as cholangiocarcinoma, gallbladder cancer, pancreatic cancer, ampullary cancer of the bladder, and other malignant involvement or of the porta hepatis lymph nodes. So first is your cholangiocarcinoma. This is the second most common liver cancer, and as I have said a while ago, this is subdivided into its anatomic location. As for its risk factor, as for its causes, most of the cases is usually unknown, but certain risk factors are increasing its development, and this could range from factors such as congenital anomalies of the bile duct, which is the Carlisle disease, primary sclerosing cholangitis, and even biliary infections, which is the most prevalent among Asian countries. Next would be the another worldwide cause of cancer in the biliary tract, which is the gallbladder cancer. This has a more increased prevalence among female individuals as compared to cholangiocarcinoma, which is more common among men. And for its etiology, it is multifactorial with a primary risk factor of cholelithiasis. Another cause of biliary obstruction is your pancreatic cancer. As for pancreatic cancer, this has a high mortality and has the worst prognosis. And this is the third leading cause of cancer death in the US and even projected to cost more lives in each year. And it is associated with a lifetime risk of development, which primary would be the age of the person. It is diagnosed among 65 to 74 years old men And environmental factors could also increase the risk of developing pancreatic cancer, with smoking as the primary risk factor. Also, for the diet, high intake of fat or meat and consumption of sugar fizzy drinks could also increase its development. Also, family history of pancreatic cancer and lifestyle diseases such as diabetes mellitus could also be a risk factor for a person to develop pancreatic cancer. Next is the cancer of the ampulla of Vater. This is most highly associated with the risk factor of familial adenomatous polyposis and other genetic diseases such as Gardner syndrome, which is also another type of or a variant of your familial adenomatous polyposis.
Yes, Dr. Chan.
I have nothing against the differential diagnosis of the malignant obstructions of the extrahepatic biliary tree, but Dr. Aguse, you have to mention also that although gallbladder CA is a differential diagnosis, that it is very unlikely in the patient because the patient already underwent cholecystectomy in the past.
Yes, Doc po, noted po. Sorry. Hello?
So I'll be presenting the hello. Could you hear me clearly?
Yes, yes.
Okay, thank you. So I think the clinical manifestation for the following malignancy that we discussed. So all the malignancy that we discussed may present with right upper quadrant pain, Kobayashi sign, nausea and vomiting, and signs and symptoms related to obstructive jaundice due to cholestasis. The patients may also present with associated symptoms of cancer such as weight loss, malaise, fatigue, and metastatic nodes such as Verus nodes and Mary Sister Joseph nodes. So what
Sorry,
does
Bella.
yes, Doc.
Let me interrupt you. You mentioned that all of this cancer may produce Courvoisier sign?
Yes, it's yes, Doc. That's what I have
You meant
read about.
so meaning to say
But
patient
it's more common in pancreatic cancer. It's
yeah.
most noted in pancreatic CA.
So let me ask you once again. Cholangiocarcinoma in the hilum, gallbladder cancer.
No, for cholangiocarcinoma, only the distal cholangiocarcinoma may present with Kobayashi sign.
How about for gallbladder cancer?
Sorry, it's Courvoisier.
Okay.
Sorry. Sorry for my French. For gallbladder CA, there are some studies that says that they can also present with Courvoisier sign due to obstruction and producing the cystic duct.
Really?
Doc. Yes, Doc. It's the one of the exemptions.
Let's see. You show us later the sign, and then you tell me once more whether gallbladder cancer can produce that.
Okay, Doc. Okay. So I will differentiate the symptoms for cancer. So for cholangiocarcinoma, only extrahepatic because we're talking about obstructive jaundice in the extrahepatic biliary tract. It's only extrahepatic cholangiocarcinoma that may dilate the common bile duct. Usually, patients present with painless jaundice, though 10% of patients may present with cholangitis. Klatskin tumor may also be note with collapsed gallbladder. For distal cholangiocarcinoma, it is difficult to distinguish it early on from early pancreatic cancer due to its anatomical location. For gallbladder CA, early cases are usually accidentally discovered through routine cholecystectomy. Most patients with pancreatic cancer are hypercoagulable, so they mostly present with hepatomegaly, splenomegaly secondary to PVT, and trophosine, which is actually a migrating
Sorry again,
thrombo.
Isabella,
Yes,
for
Doc.
your initial statement, pancreatic cancer are hypercoagulable, so they present with hepatomegaly?
No, splenomegaly. I mean, one of the manifestation is hepatomegaly. For hypercoagulability, they may present with splenomegaly, Trousseau syndrome, Doc.
Okay.
And depression can also be noted and an onset of diabetes mellitus 1 year prior to the development of pancreatic cancer. And for cancer of that ampulla of Vater, unlike the 3 previous malignancy that usually present manifestation at cancer of ampulla of Vater is diagnosed early due to its early presentation of cholestasis.
What presentation other than cholestasis?
Uh, uh, the gastric outlet of so prominent, so nausea and vomiting is usually also severe in cancer of ampulla of Vater. Silver stools, which is a
What?
mixture of sorry Doc, medyo choppy. Ano po?
What is
Silver stool is the of colic stool in the malignancy, bleeding from the malignancy.
bleeding, not malignancy?
Okay, Doc.
All right. Sige.
So, Doc, so I have previously, bakit ayaw mag-change? Okay. I have previously noted Courvoisier sign. So, what a Courvoisier sign? So, what is Courvoisier sign? It is a palpable but non-tender gallbladder in the presence of jaundice. It is suggested to be malignancy than gallstone until proven otherwise. So, what is the explanation of this? The classical explanation is that gallstones usually causes repeated infection and fibrosis that will eventually fibrose the gallbladder. When it happened that gallbladder obstruct the common bile duct, the gallbladder will no longer be distendable and be palpable owing to its previous fibrosis. Unlike common bile duct obstruction due to malignancy that can still distend the gallbladder to reduce pressure in the biliary system. Though recent experiment by Fitzgerald and company has noted that gallbladder actually remained distendable regardless of pathology and suggests that it is the chronicity of the elevation of intraductal pressure due to malignancy which causes the distension of the gallbladder that makes it palpable. And as I noted, that Courvoisier sign is suggested of malignancy rather than gallstone until proven otherwise because there are some exemptions, and one of that exemption is, for example, a double gallstone that will block a gallbladder in the cystic duct. So, Doc,
Isabella,
yes, Doc.
how often do we find this sign?
Doc, they say that it is not it is oftenly only it was only often noted for cancer of the head of the tumor of a pancreas, though it can still suggest cancer. Then
My
50%
question, Isabella, how often?
Only 50%, because 50% of malignancy is non-palpable, Doc.
Okay. Now, let me go back to my question a while ago. You mentioned gallbladder cancer.
Yes,
so if you have
Doc.
cancer in the gallbladder, how can it produce this sign?
If it can increase the pressure in the common bile duct, Doc.
But you forgot the gallbladder should be distensible.
Okay.
That is the reason why I was commenting on your statement a while ago because you mentioned that all of the diseases that you presented will produce this sign. Now, another question. This is a very good question by Dr. Ruiz. Are all palpable gallbladders curvous gallbladder?
Are all palpable gallbladder covers. No, doc. It can be. Is it? Are there other disease noted for Covosphere gallbladder, doc? Is that
There
the
are other
question?
diseases that may produce a palpable gallbladder, right? Like
Yes. Uh, 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 Chronic pancreatitis, parasitic biliary obstruction, doc. Congenital cholecystectosis, doc.
hydrops. Dr. Ismael
Hydroxide.
answered. Okay, sige, next.
Okay, Dr. D.
Yes.
Yeah, I brought up that question is when you label a palpable gallbladder as Courvoisier, then you are referring to a malignant obstruction of the common bile duct. Do you get it? So if you say, oh, the gallbladder is palpable, but you are not sure, don't label it as Courvoisier gallbladder. You only label it as Courvoisier if you have proven that the cause of the enlargement or enlargement of the gallbladder is a malignant obstruction of the common bile duct. Okay?
Okay, doc.
Tim mentioned here that it cannot be this sign will not be applicable to our patient because the patient already had cholecystectomy. Very good, Kim. Actually, I'm just waiting for the last member to give his um, reasoning why this is malignant obstruction before we ask this. All right? But you preempted this. Thank you, Kim. So next one.
Hello, dinig po ba?
Yes, yes, we can hear you.
Okay po. Okay. So next is diagnosis and treatment of malignant biliary obstruction. So for the diagnosis and treatment, first is the extrahepatic cholangiocarcinoma. So this figure is an algorithm for the diagnosis of extrahepatic cholangiocarcinoma. Kita po yung pointer?
Yes.
Okay po. So in cases po of clinically suspected extrahepatic cholangiocarcinoma, serum levels of CA9, ERCP, and conventional as well as molecular cytologic analysis of endoscopically obtained biliary brushings of malignant appearing areas should be performed. Serum levels of your CA19-9 and CEA may be elevated in patients with cholangiocarcinoma. However, none of these serum markers is specific, and each can be elevated in other gastroenterologic or gynecologic malignancies. ERCP with brushing is used to explore cytology, and FISH or your fluorescence in situ hybridization is for exploring polysomy, which is diagnostic of cholangiocarcinoma. So your FISH enhances the sensitivity of your cytology for diagnosing cholangiocarcinoma 20 to 40%. So if the results of this test are normal or negative, close follow-up of the recommended. Management of cholangiocarcinoma should be prompted by identification of a dominant stricture, a serum CA19-9 level above 129, or a biopsy or cytology result that is positive for carcinoma or polysomy. For indeterminate cases, gadolinium enhanced MRI of the liver is recommended. If a lesion, if a mass lesion or vascular encasement is identified, management of cholangiocarcinoma should be initiated. If the MRI study is negative, but clinical concern about cholangiocarcinoma persists, PET scan can be performed. So if positive result of hotspots are identified on your PET scan, treatment for cholangiocarcinoma should be initiated. Is negative, close follow-up of the patient is recommended. If the MRI is negative and cholangiocarcinoma is considered unlikely, the patient can be followed up expectantly. So the figure shows imaging of your extrahepatic cholangiocarcinoma. Figure A is a film from ERP in a patient with perihilar cholangiocarcinoma demonstrating dominant strictures of the biliary tract. Figure B is a gadolinium enhanced MRI. The arrow points to the biliary tumor seen in a T2 weighted image. And figure C is a PET CT scan of the same patient. The biliary tumor is seen as an enhancing region pointed by the arrow. For the treatment, PCCA treatment PCCA with negative lymph node involvement is best treated by surgical resection. For unresectable single PCCA less than 3 centimeters without dissemination, they can be considered for liver transplantation with neoadjuvant chemoradiation. If lymph node involvement is present, systemic gemcitabine and cisplatin can be considered biliary tract stenting. For DCCA treatment or your distal cholangiocarcinoma, surgical resection of Whipple's procedure is the primary option for management of DCCA. So next slide.
Arnold,
Yes, Doc.
Arnold. Yeah.
Yes,
So
Doc.
if this is cholangiocarcinoma, where do you think the location? Where do you think is the location of the cancer?
In
In
the
this
perihilar
particular
region,
in this patient,
extrahepatic,
where nga?
extrahepatic, Doc.
Where?
Mm, in the common bile duct, Doc.
Where? Di ba you mentioned there's flat skin, there's distal. Where? In this particular patient.
Peri perihilar, Doc.
You think perihilar? Do you think patients with perihilar cholangiocarcinoma may present with dilated common bile duct?
Mm, distal po.
Okay,
Yes, Doc.
but even though we say this is distal, but remember your patient already had cholecystectomy. And patients
Yes,
with
Doc.
with cholecystectomy, they may have an enlarged common bile duct. But if you were to choose, most likely this is distal, right?
Okay po, Doc.
If this
Noted
is
po.
cholangiocarcinoma. Okay,
Mm-mm.
next.
Okay. Okay. Nalipat po ba yung slide?
Sige, Arnold, continue.
Wait. Ayaw po. Pwedeng pa-transfer na lang po ng slide. Ayaw po kasi. Sorry.
Ano bang gusto mo i-discuss, Arnold?
Okay. Slide 2 of 4 po.
Okay.
Okay po. So, gallbladder cancer diagnosis. So, abdominal ultrasound is often one of the first imaging studies performed in a patient who presents with symptoms of gallbladder cancer. The sensitivity of ultrasound for gallbladder carcinoma are 85% and 80% respectively. Typical imaging presentations of gallbladder carcinoma include focal or diffuse mural thickening of the gallbladder, an intraluminal mass greater than 2 cm in size, and that originates in the gallbladder wall, and a subhepatic mass that replaces or obscures the gallbladder and often invades the adjacent organs. So the figure shows the ultrasound in patient showing a large mass pointed by the white arrow, originating from the gallbladder wall and protruding into the lumen. So for indeterminate cases, Doppler ultrasound can be attempted to differentiate a malignant from a benign gallbladder lesion on the basis of the pattern of color signal, blood flow velocity, and resistive index. Next is CT and MRI. MRI and CT can be helpful in the diagnosis if the ultrasound findings are indeterminate. Helical CT scan has 83% accuracy in assessing the local extent and is therefore helpful in pre-op planning. The role of PET in gallbladder carcinoma is not routine. The sensitivity of PET for detecting gallbladder carcinoma is only 75%, and its main impact is for the detection of distant metastases. Lastly, your CEA and CA19-9 markers are most commonly used tumor markers for your gallbladder carcinoma. For the treatment, the mainstay of treatment is surgical. It's either simple or radical cholecystectomy for stage 1 and stage 2 disease, respectively. For gallbladder cancers at stage 3 and 4, they are considered unresectable. The standard of care for patients with unresectable gallbladder cancer therapy with gemcitabine combined with cisplatin. Next is pancreatic cancer. Technique is the use of a dual phase contrast enhanced spiral CT with pancreatic cancer protocol, which allows arterial phase enhancement and portal venous phase enhancement. So the figures on the left um, are selected images from contrast enhanced CT in patients with locally advanced adenocarcinoma of the pancreas. So panel A demonstrates the typical features of adenocarcinoma of the pancreas on arterial phase axial CT scan showed on the dotted outline. Panel B demonstrates the typical features of adenocarcinoma of the pancreas on portal venous phase axial CT scan in a different subject. The dotted outline in pancreas cancer is the pancreatic head. So next is the histologic diagnosis. So a histologic diagnosis is essential and should be obtained with a cutting biopsy needle. The biopsy can be obtained via endoscopic ultrasound guided technique for a tumor localized to the pancreas. PET scan can demonstrate metastatic disease and again CEA and CA19-9 markers. Um, these are these markers are useful in following the course of pancreatic cancer. For pancreatic cancer treatment, Table 79-3 presents another clinical way to express the extent of disease as well as therapeutic approach. For patients with resectable disease, as defined in the table, the best option is surgery. For patients with locally advanced disease, therapeutic approach includes either chemotherapy or chemotherapy plus radiation therapy. And for metastatic disease, the therapeutic approach is systemic chemotherapy. Okay. Last is your ampullary carcinoma. So usually, ampullary carcinomas are diagnosed by endoscopy on the basis of their macroscopic appearance and findings on biopsy. The figure on the left shows endoscopic appearance of your ampullary carcinoma. Often, endoscopic ultrasound or your EUS is used in the pre-op evaluation. Its accuracy for detecting invasion of adjacent organs is 90%, and sensitivity and specificity for detecting vascular invasion are 73 and 90% respectively. Elevated serum concentrations of your CEA and CA19-9 are also been detected in patients with ampullary carcinoma. For the treatment, surgical resection is the only curative treatment for ampullary carcinoma. The standard surgical approach is pancreatico-duodenectomy. Another treatment option is your adjuvant chemotherapy with 5-fluorouracil-based chemoradiation. And lastly is your palliation. So palliative treatment should be directed at alleviating tumor-associated complications with the goal of optimizing the patient's quality of life. Obstructive cholestasis is a major cause of morbidity and can usually be treated palliatively by endoscopic or percutaneous placement of a biliary stent. Thank you.
Hello, good morning po. Can you hear me?
Good morning. Yes, we can hear you.
Okay, so today I will be presenting on the prognosis. So as mentioned earlier, the only curative option for extrahepatic cholangiocarcinoma would be surgery or transplantation. Most patients with extrahepatic cholangiocarcinoma will have a poor prognosis, and the reason for this will be because they are usually diagnosed at advanced stage, usually stage 3 and 4, and by this time the tumors are unresectable. But for those patients who have undergone treatment modalities, it is noticed that for N0 patients after
R0 resection, R0 meaning that they have negative resection margins, the 5-year survival rates would be 11 to 67% for perihilar cholangiocarcinomas and 27 to 37% and or about 25% according to Harrison's for distal cholangiocarcinoma. So excuse for the typo, this should be cholangiocarcinoma. However, we should note that R0 resectability rates are less than 50% and lymph node metastases are commonly observed with this type of carcinoma. So having N0 patients after R0 resection is not that common. The Whipple's procedure, which is the surgical option for distal cholangiocarcinoma, would achieve a median survival of about 2 years. And for unresectable tumors, for single perihilar cholangiocarcinomas less than 3 centimeters without dissemination, a treatment to be considered would be liver transplantation with neoadjuvant chemoradiation, and the 5-year survival would be 70%. For patients presenting with perihilar cholangiocarcinoma and PSC, or primary sclerosing cholangitis, they can also be considered for liver transplantation with neoadjuvant radio and chemotherapy. And 5-year recurrence-free survival rate would be 65%, while 10-year recurrence-free survival rate would be 59%. For unresectable tumors, they observed that there was a 3-month overall progression-free survival benefit for gemcitabine oxaliplatin combination therapy, and this is now used as standard of care for unresectable cholangiocarcinoma. Next, gallbladder carcinoma will also have a poor prognosis for the same reason that most patients are diagnosed at an advanced stage, and by this time the tumors are rarely resectable and only a minority would be considered as surgical candidates, about 15 to 47% of patients at the time of diagnosis. The prognosis is dismal with 5-year survival rate of 0 to 10% and a median survival of less than 6 months. So for the next bullet, I would just like to show the trend that as the stage progresses, the 5-year survival rate would also be poorer. And usually we catch our patients at the late advanced stages at time of diagnosis. And for after treatment, most for T1 tumors, they can be treated by simple cholecystectomy, and the 5-year survival rate would be 85 to 100%. And for T2 tumors, radical cholecystectomy would result in 5-year survival rate of 59 to 90%. We see that for early stage tumors like T1 and T2, resection is still possible and would give you a good prognosis. However, as I mentioned earlier, we rarely catch our patients in these early stages, and usually we only see early stages as an incidental finding after a patient has undergone cholecystectomy for either cholelithiasis or cholecystitis. And then surgical approach for T3 to T4 tumors are controversial. However, for gallbladder carcinoma patients, they consider this as another treatment option because of its survival benefit. So they saw that the 5-year survival rate after radical cholecystectomy for T3 tumors would be 15 to 63%, while T4 tumors would have 5-year survival rate of 7 to 25%. And for unresectable gallbladder carcinoma, there was a survival of 3.6 months when given gemcitabine with cysteine. And out of the 3 that I've discussed so far, the worst prognosis would be seen in pancreatic carcinoma. The reason being as same as the previous 2, that they are usually diagnosed late in the disease when the tumor has already progressed, and prior to treatment, only 10 to 10% of patients, according to Harrison's, and 15 to 30% of patients, according to Schlesinger, have resectable disease. It has the worst survival rate of any cancer with an overall survival of 8.2% regardless of stage. And after treatment, we see that the 5-year survival rate after resection would be 25%, with a median survival of 12.7 to 24.1 months. So this is the rather low. And for smaller tumors and lymph node negative disease, even after treatment, 5-year survival rate would only be 20%, with a median survival of 18 to 23 months. and 30% of our patients upon diagnosis would have locally advanced disease, and after treatment, their median survival would only be 6 to 10 months, and majority of the patients upon diagnosis would already present with advanced metastatic disease, and treatment with single-agent gemcitabine would only give the patient median survival of 6 months and a 1-year survival rate of 18%, with a median overall survival of 6 to 11 months. And on a good note, we should know that ampullary carcinoma has a better prognosis out of the 4 malignancies that I've mentioned. This being that ampullary carcinomas are diagnosed early, that's why we are able to catch them at earlier stages of disease. Prior to treatment, 77 to 93% of patients are resectable at the time of diagnosis. But we must note that nodal involvement for this malignancy is a negative predictor of overall survival. So we see that the 5-year survival rates for node positive would be 9 to 47%, while for those who are node negative would have a higher survival rate of 59 to 63%. But overall, at the time of surgery, about 42 to 60% of patients are found to have lymph node metastasis. So after treatment, the 5-year survival rate of those without lymph node metastasis would be 59 to 78%, but while those who have or who are positive for lymph node disease would have a lower survival rate of 16 to 25%, and for those with extracapsular lymph node involvement, this is further decreased to 9%. Lymph node positive patients with adjuvant 5-FU-based chemoradiation, their 5-year survival rate was seen to increase from 6 to 28%. And median survival with adjuvant 5-FU plus folinic acid would have 58 months median survival, and if given gemcitabine, they have an increase of 71 months median survival. This is compared to if without adjuvant treatment, it would only be 41 months. So we see that adjuvant therapy has a role in lymph node positive disease.
So,
So
Janine, as the last
finally,
member,
as the last member of this differential, the reason we consider malignant biliary obstruction as a differential for our patient is because of the PE finding of painless obstructive jaundice. And aside from that, we also have risk factors like the age, gender, and smoking history, which can predispose for malignant biliary obstruction. Thank you.
okay. So before you leave, Janine, if this is truly malignant biliary obstruction, which one of the cancer do you think the patient has?
For me, I would consider most likely 2 differentials, which would be cholangiocarcinoma and pancreatic cancer.
If just to choose one. Which among the two? Cholangio or pancreatic cancer? Most likely. Sige. No answer?
Doc, pancreatic carcinoma na lang po because
Like,
of smoking.
mas common. All right. Sige, next.
So, strictures of the bile duct is the narrowing of the bile duct, which then prevents bile from draining into the intestine. The bile backs up to the liver, thus causing obstructive jaundice. Strictures of the bile duct can be benign or malignant, and today we will be focusing on the benign causes. First, benign strictures of the bile duct most often arise from post-operative trauma, which results from cholecystectomy, major hepatic resection, and liver transplantation. It usually occurs following injury during a cholecystectomy, accounting for approximately 80% of such cases and predominantly involves the common bile duct. The incidence rate of major bile duct injury is higher after laparoscopic cholecystectomy compared having an open cholecystectomy. As for liver transplantation, benign strictures of the bile duct occur in approximately 10 to 40% of cases, and most commonly occur at the anastomotic site. And with these, trauma will present with bile leak or abscess formation in immediate post-operative period, or with biliary obstruction or cholangitis as long as 2 years or more following the inciting trauma. We highlighted cholecystectomy red because our patient underwent cholecystectomy last 2004. Another cause is chronic pancreatitis, which results from the repeated inflammation and scarring of the pancreatic head, which accounts for up to 10% of the benign biliary strictures. Another cause of benign biliary stricture is primary sclerosing cholangitis, which is characterized by a progressive, inflammatory, sclerosing, and obliterative process affecting the extrahepatic and or the intrahepatic bile ducts. It is predominantly seen in male in their third and fourth decades in life, and it occurs for up to 90% in association with it it occurs in association with inflammatory bowel disease, especially ulcerative colitis. It may also be associated with autoimmune pancreatitis, multifocal fibrous sclerosis syndrome, Riedel struma, or pseudotumor of the orbit. The benign stricture results from the fibrotic inflammation and may be multifocal intrahepatic or extrahepatic in location. Biliary disease, which has indistinguishable biochemical and cholangiographic features from primary sclerosing cholangitis, is the immunoglobulin G4 associated cholangitis. It is of unknown origin and often associated with autoimmune pancreatitis and other fibrosing conditions, with elevated serum IgG4 levels compared to primary sclerosing cholangitis. For hepatobiliary tuberculosis, like other any extrapulmonary tuberculosis, it is due to the Mycobacterium tuberculosis. The organism may reach the hepatobiliary tract by the hematogenous route from a tuberculous infection of the lungs via the hepatic artery. This may present with bile duct involvement causing obstructive jaundice, either by enlarged nodes surrounding the bile ducts or actual tuberculous process in the ductal epithelium, thus causing the stricture. So our patient had a history of tuberculosis. That's why we highlighted it red. Thank you.
So good morning. We're going to talk about the clinical manifestations of our patient. So as for the clinical manifestations of the different causes of benign biliary strictures, they are generally similar in presentation with some differences. Highlighted in red are the pertinent positives in our patient, namely jaundice and tea-colored urine. So as you can see, the symptoms are very similar from the different shows, from abdominal pain to jaundice, with slight variations, such as the association of primary sclerosing cholangitis with inflammatory bowel disease and hepatobiliary TB with history of tuberculosis. Along with the symptoms, the laboratory workup of the patient with benign biliary strictures also posed similar results, such as elevated transaminases, elevated serum bilirubin, specifically total indirect and alkaline phosphatase. If left untreated and would become in a chronic state, this may progress into secondary biliary cirrhosis, portal hypertension, and worse, end-stage liver disease. Thank you.
Yes, Sina? Sheena?
Dok,
Hello,
nagkakaproblema
Doc.
lang po si Sheena.
Hey, Sheena?
Hello.
Yes. Good morning.
Good morning po. Sorry po for the technical difficulty. So for the diagnosis, first here is MRCP. So this is a purely diagnostic procedure, and as you can see, this can only visualize the pancreatic and the biliary duct. So it is said to have a very high sensitivity when it comes to diagnosing strictures, dilatations, intraductal abnormalities. And as for our case, we are showing photos of said strictures. So I have arrows here pointing at the strictures. As you can see, you can only see the strictures, but for our case, we are tackling about a benign stricture. In MRCP, we cannot really determine if it's benign or malignant. So, which leads us to the next slide, please. So here we have ERCP. This is both diagnostic and therapeutic procedure. And as for its therapeutic use, I'll discuss it later. I'll show you how it can be therapeutic. But as for its diagnostic use, this is actually the cholangiogram of choice when it comes to absence of dilated ducts. So with absence of dilated ducts, we mean we can use it in diagnosing strictures, like in our case. So the advantage of this ERCP, comparing it to what was earlier mentioned in MRCP, is that we can actually do tissue sampling through ERCP, and this would be helpful because through biopsy, it's the only way that we can really confirm if the said stricture is malignant or benign. Here you could see photos. The arrows are actually pointing at the strictures. For both ERCP and MRCP, they actually show us similar pictures of the strictures. According to literature, they are said to have certain characteristic. So when it comes to benign strictures, they are said to have shorter length, and at the same time they are said to have smooth taper. Comparing it to let's say a malignant stricture, which would usually present with an abrupt taper and a longer stricture. So next would be percutaneous transhepatic cholangiogram. So this is both diagnostic and therapeutic. Like ERCP, they're both diagnostic and therapeutic. However, we only do PTC when ERCP is contraindicated or when it has failed. So the last photo in this slide shows us how PTC is done. So we enter percutaneously through a needle, and then a guide wire is placed, etc. So next slide, please. Yes, so we are going for the treatment already. So for ERCP, it could also be a therapeutic procedure through the placement of stents. So placement of multiple side-by-side large bore plastic stents over the course of several endoscopic sessions, with stents remaining in place up to a year. So with this one, you can see first photo points at the stricture, the second one points at the balloon dilatation, and then third would be the placement of the plastic stents, and fourth, that's actually the follow-up cholangiogram showing us that there could the improvement when it comes to the diameter of the duct. And as an alternative, some sources would say SEMS, or the self-expandable metal stents, can also be used. And these are removed 3 to 6 months after. However, certain literature say that there's not yet an approved guideline as to using SEMS for benign strictures. Next slide po. For, as mentioned earlier, both PTC can be both therapeutic and diagnostic. So it's basically the same as ERCP. We're only entering it through percutaneous way. And for combined percutaneous and endoscopic approach, also known as the rendezvous procedure, this can be done in certain situations, like when ERCP is unsuccessful, but the bile duct still needs to be accessed endoscopically. So we enter percutaneously, we enter through a guide wire into the duodenum, and then ERCP is repeated. So for the photos, I'm not sure if you could see it, but the first photo just shows us shows us that there is a stricture. The second one shows us the dilatation, balloon dilatation, and the third would be showing us the improved bile ducts. As for the last slide, surgery. So this is what we do when everything else fails. So when ERCP or PTC are not successful, then we resort to surgery. I will not go in depth into this, but certain literatures would say that the type of surgery would depend on the location of the stricture or the certain etiology of the stricture. And in summary, we think that this is a case of benign biliary stricture, primarily because the patient actually has a pertinent history of cholecystectomy. So these strictures are actually pretty common when it comes to. Yes, po,
Tina,
doctor.
please start again
Yes,
with
doc.
the presentation of the patient. The patient presented with obstructive
Jaundice, doctor. So with a patient presenting with obstructive jaundice, um,
you considered
we considered benign biliary stricture because there is also a pertinent history of cholecystectomy po, which could lead to benign strictures, as um, 1 in every 500 cholecystectomies are said to lead to these strictures po, doctor.
so Rovelin, final diagnosis.
Um, because of the patient's presented symptoms and previous cholecystectomy and TB infection, our diagnosis is leaning towards benign obstruction of bile duct, secondary to post-op biliary stricture. However, confirmatory procedure should be done for final diagnosis.
Dr. Chan, yes?
Rovelin,
Yes,
after
doc.
your diagnosis, I would just like to know what do you intend to do for the patient. Now, let's go back to the history of the patient. And after discussing all the possible diagnostic procedures that you can do in patients with jaundice, what will you do now for the patient at hand?
Doc, we would do primarily treatment po for or confirmatory diagnosis po, doc.
So what do you intend to do?
Treatment for benign strictures such as
No,
RCP
I'm
or
not.
placing biliary
I'm not
stents.
implying that you're dealing with a benign stricture. I'm just asking you. You have a patient now with all the problems as presented in the history and the physical exam. What do you intend to do now for the patient, without considering it your diagnosis, Albert?
Yeah. You need to confirm the diagnosis, whether this is choledocholitis, malignant or benign stricture of the bile duct, and therefore you need additional examinations.
Yes, doc.
Oh, so what will you?
We could do ERCP po. imaging
Railways? You have a very high
is diagnostic and
suspicion for choledocholitis that you
sorry, Doc.
will go straight to ERCP?
Doc.
Do
Sorry,
you
hindi ko po
start right away with an invasive procedure, knowing that you have a...
MRCP po, Doc. We can start there.
Do you agree, Dr. Chan?
Well, it's like this. It depends. But regarding this case, a patient only has jaundice, has a dilated common bile duct by ultrasound. There is no evidence that the patient is in cholangitis. So I will not proceed with something as invasive as an ERCP. Maybe I will go with an MRCP first.
Yes, Doc. Noted po.
Okay. If no other questions, then we'll conclude this BGD 7.
Okay. Again, just a reminder to give us a feedback. Are the presenters for the last BGD ready? Christian, are you raising your hand because you're a presenter? Okay, Dr. Wong?
I'm here. Yeah, we can proceed if everyone's ready.
Okay.
Christian, if you're ready, we can start.
Christian, go ahead.
Ay, sorry po, nakamute po pala ako. Okay, ulit, sorry. Okay, so good morning everyone. We are B8, and today we'll be discussing a case on acute medical abdomen. So this is the case, and let me just read out the salient features. So the patient is a 42-year-old male with a chief complaint of epigastric pain. The pain is described to be steady and boring, severe, of sudden onset, and has lasted for 48 hours. The pain radiates to the interscapular area and is relieved by sitting with the trunk flexed and knees drawn up. It's important to admission the patient had an alcoholic binge, and 2 years prior to admission, a similar severe pain, which radiates to the back and was relieved after 2 hours, was experienced by the patient. The patient is a smoker and drinks 5 bottles of beers per week. Other pertinent data includes a family history of gallstones. Upon physical examination, the patient is conscious, coherent, and in pain. He is normotensive, tachycardic, tachypneic, and febrile. His BMI is normal. Upon inspection, the patient had icteric sclera and a slightly distended abdomen, which was tympanitic on percussion. He had hypoactive bowel sounds and a tender epigastrium. No abdominal mass was palpated. So before we proceed with the case, let us first define what an acute abdomen is. An acute abdomen is a spectrum of medical, surgical, and gynecologic conditions wherein the primary symptom is abdominal pain. The pain is less than 1 week in duration, and patients usually seek attention within the first 24 to 48 hours. An acute abdomen always warrants further evaluation and urgent treatment, either medical or surgical. So an acute abdomen can either be an acute medical abdomen or an acute surgical abdomen, and their difference lies mainly in their management and treatment. Usually, patients with an acute medical abdomen are hemodynamically stable. Study should be performed as soon as possible to determine the etiology of the abdominal pain. Treatment: medications, IV fluids, bowel rest, and nasogastric decompression if needed. On the other hand, patients with an acute surgical abdomen are hemodynamically unstable and in shock. There are evidences of ischemia, perforations, and adhesions. Evidences of peritonitis, such as reluctance to move or speak, rebound tenderness, involuntary guarding, and a board-like rigidity of the abdomen are also present. Hemodynamic resuscitation must first be performed before imaging studies are done. So treatment would of course be surgery.
Okay. We will now of the various causes of acute abdomen. So it's important to note that acute abdominal pain may have its etiology in disease processes outside the abdomen, such as those shown here. So for example, we have myocardial ischemia and infarction for cardiac causes, and diabetes ketoacidosis for metabolic causes. However, for the sake of today's discussion, we will focus on the intra-abdominal causes. So shown here are the more common intra-abdominal causes according to Schlesinger. Those underlined are the differential diagnoses, and we will expound on that later in the other parts of the BGD. The discussion in this part will focus on how the listed conditions are managed, which will help us classify which cause acute medical abdomen or acute surgical abdomen. So of the conditions shown here, those that require surgical intervention, or in other words, those that cause acute surgical abdomen, are as follows. So first we have acute appendicitis. Although there is increasing evidence of the value of medical antibiotic administration as definitive treatment for acute appendicitis, the standard of care for both uncomplicated and complicated or perforated appendicitis remains to be appendectomy. Next, we have perforated peptic ulcer, which leads to peritonitis and also requires surgery. For acute mesenteric ischemia, especially those that are of embolic or thrombotic in origin, immediate revascularization and bowel resection is required. And finally, a rupture of the abdominal aortic aneurysm presents with the classic triad of hypotension, pulsatile mass, and abdominal pain. And this also requires immediate surgical intervention. So in some cases, a clear-cut distinction cannot be made as to whether the condition causes either acute medical or acute surgical abdomen, because a patient may require either medical or surgical intervention depending on where he or she is on the spectrum of disease. So for acute biliary disease, for example, this encompasses both acute cholecystitis and acute cholangitis. So for acute cholecystitis, the mainstay of therapy is surgical, so cholecystectomy is performed. However, for acute cholangitis, management is mainly medical, involving antibiotics, fluid resuscitation, and rapid biliary decompression using endoscopic techniques such as ERCP. So according to Schlesinger, there is a dramatically lower morbidity and mortality associated with ERCP compared to surgical decompression. Next, we have small intestinal obstruction. So for partial small intestinal obstruction, initial treatment is medical with bowel rest, IV fluids, nasogastric decompression, and close observation. However, if there is complete obstruction or if there is failure of conservative management, then surgery will be required. For acute diverticulitis, the severity is described using the Hinchey grading system. Those with Hinchey grade 1, which is a localized pericolic abscess or inflammation, frequently require hospitalization for IV antibiotics, while Hinchey 2 diverticulitis, which is a pelvic, intra-abdominal, or retroperitoneal abscess, should undergo CT-guided drainage of the abscess and also receive a course of IV antibiotics. In contrast, with Hinchey grade 3, which is generalized peritonitis, and Hinchey grade 4, which is generalized fecal peritonitis, frequently require emergency surgery. And finally, we have acute pancreatitis. Although most cases of acute pancreatitis are self-limited, as many as 20% of patients will have severe disease with local or systemic complications and therefore will require treatment. As you will learn later on in the discussion, the management of a patient with acute pancreatitis consists of supportive care with fluid resuscitation, pain control, and nutritional support. Immediate laparotomy may be required for a minority severe acute pancreatitis who present with a profound intra-abdominal catastrophe such as colonic ischemia. Moving on, this table shows a comparison of the different causes of acute abdominal pain according to pain onset, location, character, descriptor, radiation, and intensity. We can focus our attention on the diseases in the yellow box, namely cholecystitis and pancreatitis, as the description of pain associated with these most closely resembles that of the patient in our given case. So for cholecystitis, the pain is acute in onset and is localized to the right upper quadrant. It is described as constricting, may radiate to the scapula, and is of moderate intensity. And to reiterate what was said earlier, acute cholecystitis requires surgical intervention, specifically cholecystectomy within 48 hours. As for pancreatitis, the associated pain is also acute and can be localized to the epigastrium or back. It is described as boring and radiates to the mid-back. The pain ranges in intensity from moderate to severe and be successfully managed through medical means, with surgery being reserved for management of complications and for pancreatitis from specific etiologies, as will be discussed later on. We'll now move on to the different diagnostic tests that will be used for the evaluation of acute abdominal pain.